Welcome, everyone. I am Kylie Petersmith, one of the co-chairs of the Alliance for Nurses for Healthy Environments Practice Committee. I get to introduce Nicole Benegas and Liz Schooler, who are with us today to present on the Bluebird Storytelling Series. This is the second part of a two-part series. Nicole Benegas is the executive director for Bluebird Cultural Initiative. And Liz Schooler is a colleague of mine who is a professor at Nebraska Methodist College. And the two of them are going to speak a little bit about how nurses can collaborate for a practice change in the community. And I'll transfer it over to you.
Good afternoon. My name is Nicole Benegas. Like Kylie said, thank you. I'm the executive director for Bluebird Cultural Initiative. I'm an enrolled member of the Sicangu Lakota from Rosebud, South Dakota. I also come from the Honktawa people from Yankton. We're just going to start today with a recap from our session 1 on environmental justice. At Bluebird, we really focus on community engagement, empowering youth, and working with community partners and allies. And when we talk about environmental justice, it goes hand in hand with Native Americans across the board, from history of first colonization to current. So with our young people, we really look at the activism parts and movements that have historically happened with Native people, really fighting for water, land, voting, and our cultural rights, and how that directly affects the community health. Bluebird was established in 2016, which came out of the Standing Rock encampment, protesting the DAPL pipeline that was going through there. And so we've continued that environmental kind of justice with our young people and families. How do they advocate and really show up for each other and for other things that are important? So with the Indian Self-Determination Movement and Educational Assistance Act of 1975, this was an act that actually gave this was an act that gave Native Americans the right to operate their own healthcare systems and education. It allowed for negotiation between contracts for like federal funding for education and healthcare up to Indian Health Services was established in 1955 and initially was ran through the federal government. Not until really 75 is when we as Native people and communities were able to say, hey, our healthcare needs are different, and that we were able to run our own facilities on the reservations or serving Native people across the nation. Go ahead. So from part 1, I don't know if we had anybody on here from the previous one, if there was any thoughts or questions that may have came up since the last time we had met. I do know that in the first part of this series, we really talked about just historically what does that activism and look like in the Native community around environmental justice. We are located in Omaha, Nebraska. Our nonprofit is headquartered out of Omaha, but we do serve across the 50 states, primarily in the Great Plains region, but do a lot of work in the Southwest as well. We work with the Smithsonian in different places. I know that we are serving an urban setting, and so one of the questions was around how can you create that support system? And in an urban setting, when you're serving different tribes, there are 574 federally recognized tribes, especially when you look at the coastals. There are actually tribes that are not federally recognized because they did not enter into agreements with the federal government, but there are a lot of tribes that are state recognized, but then they don't qualify for those federal programs like Indian Health Services, which you have to be a member of a federally recognized tribe. Um, One thing I would say as nurses or people that are in the healthcare field, it would be really a way to kind of collaborate and look at how do you get involved with a Native community that you are that is around you in your area would be to see if there is any native centers like community centers or maybe nonprofits or organizations that you could try to build relationships with, as well as looking to see if there's are any Indian Health Service clinics or urban Indian health clinics that may be in your area or close to you. For environmental justice challenges, one I really wanted to highlight was one because we do, as an organization, we were established from Standing Rock encampment, and that was really to protect the waterways in which the pipeline was going through. It was very much targeted on the fact that we didn't want our waterways contaminated. When we look at water, right now, so in Nebraska itself, one of the four tribes that is headquartered in Nebraska is the Isanti Dakotas, or for the Santee Sioux, as they're known. And so they've actually been on a no consumption order from 2019 to 2024. They still have a no consumption. Their water is not safe to drink, cook, or to even use to brush teeth. But with that, the the tribe there has, with federal funding and with grant funds, they are providing bottled water to the community residents, which that is about 2 cases of water per household. And so, especially when you're looking at like how does that relate to healthcare? The magnesium levels that they found in 2019 were 50 times higher than the legal standards. They draw the water source that they have draws from a creek well that also has high nitrogen and coliform bacteria found in it, and their the estimate to the kind of plan that they have came up with that reservation is that they need a new waterway system put in that would cost about $40 million to put in a 40-mile pipeline that would actually bring water from South Dakota to the reservation there. That has been a lot of setbacks just with funding available. There was some agreements in around 24 that the federal government had built into their budgets to assist with some of that funding. And then when things changed in 25, there was barriers to getting that funding actually secured. And so they still are on a no drinkable water with that magnesium. Even boiling the water, it actually brings out the magnesium more, making it a higher level. And so, I mean, we definitely are seeing how that affects the community around there and their healthcare. But water across the board for Native communities, 48% of Native households lack access to reliable, clean drinking water, and that's on all tribal, like across tribal lands, which comes out to about roughly 1 in 10 lack safe tap water to even drink from their homes. With the Navajo Nation, there's 30 to 40% of 137,000 that are on the reservations there that live without running water at all. And a lot of that is due to the uranium mines that were abandoned and have contaminated the waterways there. And so native homes are 19 times likely to lack indoor plumbing in their homes. And so even when we talk about Santee and that magnesium levels, that is deteriorating the plumbing that they have in the homes as well. When you have such high poverty rates and not accessible drinking water, like they're not going to be able to, they can get a water well system kind of put in if they get that 40 million to redo that. But still, what are those challenges in when you have had water running through those pipes for the last 10 years, that is corroding them and making them worse. So they're going to continue to see issues coming from that. But just even the poverty research will always, research is a big challenge across the board when we're looking at data, when we're looking at collecting data. If you look at suicide rates, even, it's projected about 40-50% of it is 40 to 50% less. Sorry, is less reported than what the numbers are actually showing, and that's because of the landscape of reservation settings and how spread out the community is. But also looking at when you're collecting data in healthcare systems, majority of Native people are multiracial. They come from different backgrounds, and we kind of get lumped into a other or two or more races category. So then we kind of that continues to feed into the unaware or not being part of the conversation when you're not listed as an actual like population and just listed as other. So it's not targeted to really look at that community. But other challenges when we see with healthcare is just there's so many different jurisdiction systems that there's federal, tribal, and state jurisdictions. You have a reservation that is federal, that is on federal land, but is ran by the tribe. But the federal government has a say so in those things as well. But even here in Nebraska, we have two tribes, the Omaha and Winnebago people of Nebraska, who are within 10 miles of each other, but the Indian Health Service hospital is in Winnebago. If you're in Omaha, they have a different tribal system than the Winnebagos, or if you're in Macy, where the Omaha people reside, you have to go through their tribe, Omaha tribal systems, then you go through actual state land in the 10 miles before you get to the next reservation. So you're crossing across those different jurisdictions, and then you're back into another tribal, a different tribal system to just get those healthcare services there. So I think that that also affects the healthcare follow up and just understanding like how detrimental things can be, especially those environmental justices, how that affects when we're losing track in those different systems that we're going across. And then if you look just at reservations, when we talk about reservations as a whole, reservations were set up specifically designed to be on pieces of land that were undesirable. They were the land that was not, they were relocated to land that was set aside by the government. That government, the United States government found that land to be undesirable for them to use because it was not good for harvesting or gardening or, growing crops or anything like that. So they said, sure, we can put you guys on this land set because it's not useful for us. But that also fed into taking them away from their traditional homelands of having very nutritious plant-based diets and being able to hunt what they were used to. And then they were set onto reservation lands where they had to rely on the federal government for rations, commodity programs that did not provide even fresh meat or fruit or anything like that. And not until the mid-90s did they actually have set up a new system or revamp that commodity system where they were able to get fresh fruit into there. And we still see them are very big food deserts on the reservations now. And then looking at just Rosebud in general, poverty is one of the biggest things. There's no access to health care. That is, there is a hospital there, but even lacking the ability to get surgeries that you need done or being able to get testing done for STIs or anything like that, or you're not able to, you can get a testing done, but they even talk about how they don't have enough resources to be able to provide antibiotics and the medications needed if somebody was to test positive, and being able to follow up. And there on Rosebud itself, there's about 30,000 enrolled members. So we're one of the largest enrolled tribes, but we still don't have basic access to healthcare in our clinical or hospital settings. Go ahead.
So thanks, Nicole. Like Kylie said, my name is Liz. I'm a colleague of Kylie's here, assistant professor at Nebraska Methodist College, and I teach undergraduate nursing. And I was asked to join this call to talk a little bit about how nurses can respond and explain some kind of grassroots collaboration that we did here at the college with Bluebird Cultural Initiative. And I think the obvious way nurses can respond is through advocacy, and this group is already really good at advocating and really aware of that. But when we learn about these underserved populations that really are difficult to get accurate information about, it can prepare us to bring awareness on a systems level to that population and the unique challenges they face. So at Nebraska Methodist College, we wanted to do that, and we decided to start this Immersive Journeys course to teach our students about reservation life, disparities that Native American populations face in healthcare. And we had a course that ran years ago, pre-COVID, where students did service learning on the Rosebud Reservation. And I wasn't here when that course ran as faculty. I was here as a student and didn't take the course at that time. So I can't speak much to how it ran or what collaboration happened or how much cultural immersion happened, but I know that the students did always report gaining valuable insight from the time they spent on the reservation. So it's just what started as kind of a hallway conversation led to me reaching out to Bluebird Cultural Initiative and saying, do you think we could get this going in a new, revitalized, really culturally grounded, community informed way with a big focus on relationship building and shared planning of the course to see how it'll go. And so that approach led to a really strong welcoming partnership and an invitation to return to the reservation and continue doing what we started. So when I was thinking about how did we do this or how do we respond, I just wanted to highlight our code of ethics as a profession because I made kind of a model for how we, to explain our process of how we got this going and how hopefully we can duplicate it with other populations. But really, it all lives right here, right? So, Provision 8, bridging collaborative relationships with healthcare and non healthcare folks to achieve public health goals. And Provision 3, establishing a trusting relationship and advocating for the rights, health, and safety of recipients of nursing care, which is everyone. And so, I think our ethical provisions do a really good job of highlighting that importance of establishing that trusting relationship and having that collaborative approach. And then, of course, Provision 10 that you guys, I'm sure, focus a lot on promoting human and environmental health. It's all right here, what we really did, but we tried to conceptualize it a little for all of us thinkers and describe what we did. So what this visual is meant to represent is how we approached our community engagement and culturally immersive service learning course that we built at NMC with Bluebird Cultural Initiative to the Rosebud Reservation. And we started with that step one at the top, building relationships. So NMC really started building relationships with Bluebird Cultural Initiative and the Native community they serve several years ago. Showing up at a couple of their events when invited with our mobile diabetes unit where we can do health screenings, and bringing a couple of faculty to some of their culture nights to just listen as the youth were learning and try to learn from them. I invited Nicole to come speak to my fundamentals nursing courses about the impacts of the social determinants of health that they were learning about in theory on Native communities and the communities she really walks alongside. We volunteered when asked to teach some lessons at their Ishnati coming of age ceremonial camp about women's health and coping skills and things where a need was identified. So that relationship building was and is and continues to be the most important piece, but really kind of long work of just showing up when we can and when we're asked to, and inviting Bluebird to show up and help spend time and teach us here at the college as well. So then we came up with this idea that we wanted our students to learn about reservation life and health, and we wanted to provide a little bit of some healthcare services, hopefully, in the process. And of course, we have to complete a needs assessment next. So, what do our students need in order to be prepared to go? What do we want our students, and what does the community want our students to learn from this? And what services should we offer, or what needs might there be in the community that maybe if we bring a bunch of nursing students and a handful of nurses, we could help address in a small way. So, as you all know, the beauty of a needs assessment is that you learn of needs you never thought of. And when you get that information right from the community at the center of all of this, you get to figure out ways you can approach it that you never thought of. So one small example is how we were thinking very medically in terms of the needs, health screenings, immunizations, things of that nature. And the biggest ask was socks and underwear. Can you bring us socks and underwear? So we did kind of, our students organized a donation drive for that and made little gift bags to provide folks that we interacted with when we were on our trip. And then we brainstormed and planned with Nicole, was so gracious with her time, and Steve, the founder of Bluebird Cultural Initiative. We had several meetings in those brainstorm and planning phases, and we were on the phone very frequently. And we learned a lot there. We involved them in everything from designing course objectives to planning assignments, accommodations of where we would stay, what health services we would offer, how long the trip would be. I mean, every step of the way. And it would not have been at all successful without them. An example here is when we were designing our course objectives and kind of really writing this course for our nursing and healthcare students. Nicole mentioned that we should talk about culturally relevant or culturally specific assessment findings, such as ceremonial scars, and also things like kinship placements and who might make medical decisions for family and the legality of that when you have a lot of kids who are not living with a biological or legal guardian. And this education was so vital for our students in caring for the communities, and we would have totally missed that piece. So when we were taking care of the community in action, our students saw the scars we learned about and saw the hesitancy of folks to get a flu shot when they had scars on their arms. Like right away, our students were like, oh no, we learned about that. It's cool. And so that really helped with building trust with that community. And it just helped our students to contextualize what they were seeing as far as how the family structure might be different and just all kinds of assessment findings they saw during their time at Rosebud. Then we tried our idea, right? So we tried it this fall. We went up to the reservation at Rosebud for 1 week over fall break with a group of 6 nursing students and a couple of faculty and our director of community engagement, who's a nurse. And Bluebird came with us. Steve traveled with us, stayed with us, and taught us along the way. So having him on site as kind of a cultural broker was really priceless, especially in a population where finding accurate information can be difficult because of that difficulty in data collection that Nicole alluded to. So as our students spent time in the IHS Health, Indian Health System at the bedside and in the ER and in clinics and in schools, and then working our mobile unit, he was able to really contextualize that and provide how culture and history tied into some of what we were seeing. Then we evaluated it, and overall, we think it went really well, and we evaluated it in numerous ways, though. We evaluated it from our perspective, from our students' perspective, from the community's perspective, with help from partners we made along the way at IHS and Sinte Gleshka Tribal University, and with help from Bluebird. So we found some hiccups, of course. One issue was kind of charting and documentation. We went up to give flu shots, which we thought was a great idea and was well received by the community. But the IHS nurses have a system already for documenting that and tracking that. And our systems didn't mesh very well. So we had to troubleshoot that a little, and we're still working on how we can make that smoother this next go around. Another adjustment we made there in step 7 was our students had some pretty heavy emotional responses to what they were seeing. This is a world very different than what they're used to. We live in Omaha, Nebraska, which is an urban setting with a hospital. I mean, we probably have 5 hospitals within 20 miles of our college. And we were in a food desert and a healthcare desert and a area where we were on 1 million acres of rural land with many people and not a lot of resources. So we adapted mid-trip and found a telehealth way to do kind of a debriefing session with a licensed mental health practitioner, and asked Steve if he could do a bit of a cultural debriefing and reflection on what we were seeing with us on our fourth or fifth night. So there were always lots of adjustments to be made along the way. But some of the things that came out of this is our partnership with Bluebird led us to a partnership with Sinte Gleshka University. Had we not partnered with Bluebird in those brainstorming and planning phases, we never would have thought to reach out to or even really known that SGU existed, but they have an LPN program. So the center of this, what's most important and what anchors this entire model, is what you see at the center with the community involvement at every step, the co-creation, the partnering, and the idea that we're not implementing an idea for a community or even in a community for our students, but working with the community. And then the only other thing about this model is that it could look step by step, and there's numbers there, and it does, but it's not top to bottom or linear. It's really iterative, and we bounced back and forth. We made adjustments as we were trying the idea. We found new needs as we were just planning to arrive. And so just keeping the community at the center kept us kind of focused through that process. So here's a picture of us with the Sinte Gleshka nursing students, with Steve in the hat, who was our help from Bluebird Cultural Initiative, some of the faculty, some of our students, some of their students, operating our mobile health clinic that we designed to, or we brought up to design kind of some screenings that we thought might help meet the community needs. So for us in nursing, I think especially when we think about creating healthy environments, this is really critical to think about, that sustainable, meaningful outcomes don't come from interventions. They come from relationships, from trust, from hearing stories, and from really aligning with what the community values and what the community needs. So what came from this was pretty beautiful. We got to have this new partnership with Sinte Gleshka University. We were the first nursing college. They told us to partner with them in this way. And our mobile unit got to serve as this particular LPN student cohort's first ever clinical site in their program. So they started their program at the end of August. This was early in October, and we were their first clinical, where our nursing students, our BSN students, got to kind of teach and lead them in how to provide capillary blood draws and IM injections and some of those nursing skills. And this partnership really allowed us to witness something profoundly impactful, which was these students caring for their own community in this way that is unique, because there's not a lot of this type of access where we were at. So the pride that community members had in having their own community nursing students care for them and provide their screenings and give them their flu shots was really palpable. And the partnership and shared learning from the Sinte Gleshka students to the Nebraska Methodist students was so reciprocal and just really demonstrated trust and human connection, and broke down some of those traditional hierarchies of healthcare education and who's in what program and what degree and where from and all of those things. So it was really neat to see, and really embodied what we were hoping to do with this course. We were cognizant of historical trauma and mistrust of outside organizations and of the healthcare systems in general. So we didn't anticipate serving very many folks in our 4 days that we ran this unit. We ran it probably from about 9 to 4, Monday through Thursday. No, we only ran it 3 days, 3 or 4 days of running this. And we thought we might see a handful of folks. And we told our students, if you just show up and make connections, even if you don't give a single flu shot, you've done your job. That's our purpose here. Like, healthcare is so much bigger than getting to use those skills, of course, right? But we went into it with an open heart and an open mind and the intention of just being present. And we were really happily surprised with how that was received. Community members would come get screened or get a flu shot and say, I'm posting this on Facebook, or I'm going to go get my grandma and bring her back. I don't think she's had her flu shots. And the SGU students would come on the days that they weren't assigned to work the clinic and bring their family members so that they could get screened or get a flu shot. So you can see here we interacted or screened approximately 80 members of the community in those few days. There was a very measurable impact, although maybe not as important as the relationship building piece of the impact. This was awesome. So we learned a lot about the barriers that Nicole's talked about in this session and in her last session. But even beyond that, we just learned a lot about folks' situations, and they felt like we had warm, smiling faces and students who had open hearts and wanted to listen, and weren't being treated as a checklist and weren't being judged. And so folks really opened up to us, and I think this helped us to build a little trust. You'll see here we gave 76 flu shots. We did lots of blood pressure and glucose screenings, a few pediatric screenings. That's another adjustment we'll make. So we operated during the day when students were in school, so we may operate an evening clinic when we return. And that we did, of course, see a lot of higher than normal glucoses and fasting glucoses. And so follow-up is something we want to work a little bit on because the resources are so limited. But as you might have gathered from looking at the pictures, we were working in this really close quarters sprinter van. We call this as kind of our mini mobile diabetes center. And it was designed for pediatric patients. So it's real tight in there. And at first this felt like a barrier as we were trying to see more patients than we anticipated. And we thought we were going to have to problem solve this for future visits. But in reality, this small space really created safe, intimate conditions for really personal conversations that helped our students to really understand some of the social determinants of health behind the elevated results we were seeing. So we saw people who were undiagnosed, people who were diagnosed but didn't have access to treatment or medications, and people who just hadn't seen a provider in years. So the space and that one-to-one interaction and time for storytelling and opening up helped folks feel truly seen, helped build trust. And while we didn't expect to be stewards of some pretty vulnerable moments, we felt like that had a good impact on trust and really helped our students at the same time to learn about how the environment and the barriers these clients were facing impacted their health, and then helped them to really learn the importance of presence as a nurse and the importance of delivering that holistic nursing care. So the stressors that were revealed to us were of all kinds of traumas and struggles and problems accessing healthcare. And when we were talking with the Sinte Gleska nursing students, we were talking in our orientation to working on the unit about why we collect patients' demographic data, because we do collect age and race and location and things. And we shared that in Omaha, the big city where we live, there's an approximate 12-year gap in life expectancy depending on your environment, depending on if you're in the more wealthy, affluent parts of town or the parts of town with less resources. So one of the students from Sinte Gleska at Rosebud asked, what does that number look like compared to Rosebud? And while we didn't have an answer in that moment, the student said, oh, I'm sure it's way lower than it is in Omaha because we lose so many young people to suicide. So later we tried to find that data, and due to various problems with data collection and trust, it was hard to find a good, reliable number reported by multiple sources. But the numbers ranged in what we could find from 47 to 57 as an average life expectancy on the Rosebud Reservation. So while the gap in Omaha, where we're used to working, is significant, the lower side is still around 71 here where we work. So such a significant disparity there in life expectancy. And the students reported that. They knew it right away because they live it every day. And the losses in the environment the community is facing takes a toll on many young people who came onto the unit. We saw people of all ages and shared their grief of losing loved ones to suicide and overdose, and their own struggles with substance use, and the difficulty of trying to recover when you're surrounded by folks who are struggling. So we saw a couple of young men in their mid-30s who reported being on their 6th or 8th heart attack, but couldn't really share with us their disease burden and what they needed education-wise until they were able to voice kind of a heavy load of the complex family dynamics and traumas and stressors they were facing. And it was really a deep sense of loss and struggle around, and how the stressors and these losses hit a little differently in this community that we're working with who really feels for each other compared to the communities we're used to at home, where they taught us a big part of their culture and a big idea that guides their whole perspective is this idea that we're all relatives or we're all related. So this hurt and this trauma they're facing really seems to be carried by the community as a whole. And we all know as nurses about the physiological impact that can have. So we talked with folks who had symptomatic hypertension and had problems with refilling a prescription because their provider left the reservation. There's a lot of high staff turnover in this area, and the client went and reported to the one clinic that is available there at IHS, which is a first come first serve walk-in no appointment type of clinic, and overcame the barriers of transportation and of time to show up at the clinic 2 days in a row to be turned away at the end of the day because there were too many people waiting. Eventually became really symptomatic and presented to the emergency department, where he reports he was discharged with Tylenol for the symptoms and not treatment for the hypertension. So while we know that folks maybe have access to some form of care if they're an enrolled tribal member and can access Indian Health Services, it's really nothing like the standard of care we know in any other situation. So one story that really stayed with me, I'll share, is a young woman who came in for a flu shot and decided, why not? I'll agree to a diabetes screening. And her glucose came back very, very elevated, like over 600 elevated. And we could see our students start to look afraid or worried about how to respond to that. They're not used to seeing that in our hospitalized patients, or if they are, they have all sorts of interventions right there. So it was the perfect time to hop in and start building rapport and trying to understand her situation and her story while we grabbed an A1C and waited for that to run. We learned that she was one of 6 to 7% of individuals who had a job, which had a reportedly strict probation period for a year, meaning that she could not miss work to go to the emergency room that night, or she would lose her job and someone else would have it the next day. And so we're learning this, and then her A1C comes back as expected, severely elevated, which was really the last straw for this client. And we really watched her kind of break in front of us, not because of her, new health situation that she didn't anticipate finding out, but because of what it meant for her life and for her family. She reported being the sole provider for not just children, but also aging chronically ill parents. And the risk that came to her by seeking care didn't just impact her with losing her job, but it really meant losing the livelihood for her entire family. So it was really hard to navigate that. We run mobile clinics all over at our college and work in some of the poorest communities in our city and metropolitan area, including, homeless encampments and shelters and those sort of settings. And so we're very used to, the nurses and faculty, navigating complex care plans and situations. But we've never had to delay care for something that severe for several days because a whole family's livelihood depended on it. And we've never not been able to come up with other resources to offer her. We were just racking our brain and reaching out to folks we identified from the tribal university and IHS to try to come up with more resources for this client. And there just weren't any. So that was heavy by the end of the week. As a nurse and as an educator, it's hard to teach evidence-based practice and then watch your students encounter the limits of what's actually possible in these under-resourced settings and environments. So that gap between what should happen and what can happen was really heartbreaking, but our students handled it with so much grace and learned so much for it that I just want to share a little about the impact on them. This was one student, some quotes I'm sharing with permission from the students. And in respect to the situation I shared or the story I shared, she wrote, "What I saw in her wasn't just someone battling health concerns, but someone carrying the weight of a system that had been failing her long before she was even born. When you look at her diabetes on paper, it might just seem like an individual medical issue, but the truth is the roots run much deeper. They're tangled in history, in policy, and in generations of loss and neglect. Her story is a reflection of a community that has endured more than statistics can ever capture, and yet continues to hold on to strength, culture, and hope in the face of it all." So I thought she summed it up very nicely. We also, for the folks that really like data, created a pre and post survey to try to gather some quantitative data related to our 6 general course outcomes and some additional questions about the learning we hoped our students would achieve. Initially, our 6 participants had matching identifiers, and some of them couldn't remember the matching identifiers they came up with to keep themselves anonymous. So you're just looking at unpaired median changes from the pre to post data here. So we understand it's pretty limited. But in the first set of questions we asked, we saw movement from a low to moderate confidence to a consistently high confidence level in questions regarding students' sense of preparedness for providing care in a community that's under-resourced or resource limited. From a 2 to a 5, also changed from a 2 to a 5 in comfort navigating an unfamiliar clinical environment and in understanding how colonization and policy affect Indigenous health. Even in areas where students started slightly higher, such as awareness of Indigenous health barriers or recognition of social determinants of health, which they're exposed to in their curriculum, we saw a median increase from a 3 to a 5. So together, these results, we think, suggest a meaningful shift in their perspective and confidence and readiness for practice in complex, community-based, under-resourced settings. We also asked some other questions focused on more cultural knowledge and contextual understanding, and we saw even more pronounced gains. So students began a median of 1, indicating a very limited baseline knowledge in areas such as culturally grounded healing practices, historical influences on Lakota health and healing, and understanding of Lakota values and traditions. And following the experience, they had increased these all to a 5. With recognition of social and structural determinants on reservations increasing from a 1 to a 4. So we know these should be interpreted with caution because of our self-reporting of data, our low sample size, and our inability to then go back and pair the data. But we think overall these shifts point to a strong signal of impact and suggest that immersive, really community-built and informed experiences like this have significant potential to enhance both confidence and culturally grounded understanding among nursing students. I have another quote for those of us who prefer the qualitative data. We think these reflections really highlighted that the learning the students experience extends beyond this trip and can be applied to other populations as well. This student wrote, "Before this trip, I thought cultural competence meant memorizing facts. Things like knowing a few customs, learning respectful greetings, or avoiding certain phrases. It always felt like a checklist, something you could study and master, but being on the reservation changed that for me. I realized that real cultural competence isn't about what you know, it's about how you show up." So our students learned how to show up respectfully, with humility, how to listen, how to practice that art of being present in nursing, even in environments that are unfamiliar and uncomfortable to them, and in health situations and circumstances that are really unimaginable for many of us. So we hope that they learned a little bit about how to practice in a way that honors the lived experience of those they're caring for. This was a word cloud we created based on some of their reflections and information they gave us when we asked them about the impact this course had. They consistently described it as transformative. Many of them used words like life-changing. Most of them entered unsure of what to expect in the beginning, and they trusted us through some difficult moments and some unsure experiences. So we were so grateful for their trust in us. They gained knowledge that really helped them contextualize the experience through cultural workshops they did with Steve, both before and during the trip. And then they studied historical and intergenerational trauma, history, culture, art, symbology, and the culturally assessment findings. They applied this learning in a really interactive way as they took care of patients across a variety of settings, from the Indian Health System emergency department to dialysis to K-12 schools and on our mobile unit. And they left with a clear understanding of their role as future nurses, as advocates, as learners, and then they were able to debrief with Nicole from Bluebird at the college to really process what they saw and what they had learned. So the important part is, what can we take forward from this? Here at NMC, we plan to grow this program, hopefully create some immersive experiences with other Indigenous populations and other just underserved groups that we're able to build those really strong relationships and partnerships with. But what it really highlighted for us was a shift in how we think about our role as nurses in community settings. So rather than creating parallel programs, we want to really ensure that anything we want to do is already being done, thought about, or there's a reason that it's not. So our role is to really ask, where can we add value and how, rather than assuming that we know anything about what's needed. We also saw the importance of stepping outside of traditional clinical environments and into community spaces, offering screenings in these community spaces, um, specifically screening for the impact of the social and structural determinants of health really allowed us to better align our care with folks' real lived experiences. Another key takeaway was just about the power of nursing credibility. People trust nurses, we know that. We're trusted voices, and as nurses, we should all use that voice to legitimize and elevate concerns that communities themselves identify as health barriers, and bring attention to issues that might otherwise be overlooked. And a big piece of this is accurate data collection. So, an example of what Nicole alluded to with trouble with getting good data is that our Omaha metro area is it's a healthcare hub, and we have a community health needs assessment that's completed every few years, and all the hospitals that get Medicaid and Medicare funding have to take part in that. But as I was looking through that data planning this course, there's no racial group for or ethnic group for Native American or Indigenous folks. They're just in the other category, which makes it so difficult to find accurate data to represent the disparities that we know are present. So we want to advocate for that as nurses as well. And then it challenged us to think a little bit about the narrative. There's a lot of assumptions about communities, reservations, the Rosewood Reservation, all sorts of communities. We heard a lot of things like, oh, you're going there. Oh, God, why? So being really intentional about how we share our experiences, ensuring that we're not disparaging, but we're instead really lifting up strengths and realities is critical. And this included inviting Nicole and Bluebird Cultural Initiative and our community partners in to review any presentations, publications, advertisements, things that we were putting out there, so we didn't unintentionally misrepresent the population or their values. So that ongoing accountability and partnership is really hopefully going to help us build and sustain the trust we've began to build over time. So really, if there's one key takeaway from this work, it's that healthy environments aren't something that we can create for a population or fix or even really make much of a difference in ourselves. There's something we have to build in partnership. And with that, I'll turn it over to Nicole to kind of come full circle on how we can do that.
Can you hear me okay?
I can hear you. Yep.
Okay, good. I think really everything we do is just coming back to each other. So I think creating spaces for our young people, we not only focus on bridging that gap of services that are for them to access, but also that are very culturally aware and sensitive and open to without judgment and bias as they're walking in to get those services. The other thing is that we not only are wanting to, through partnerships and collaborations, bridging those gaps and strengthening the workforce that is already there, but also creating space for our young people to step into those spaces that are doing work in the healthcare systems or in education systems. One of our biggest barriers at Bluebird is for the Native population is just the educational piece. A lot of the educational systems have not been set up for our community members to thrive to their full potential. And they also have had a very limited idea of what their kind of career paths could be or exposure to those different career paths. And so through collaboration and partnerships like Methodist, but also with other healthcare systems, we provide introductions to healthcare systems and like STEM work. We advocate within the educational systems to get our young people through their high school diploma so that they are eligible to go into these other career paths while doing so. But it's the same thing with that building relationships is that we know with the partnerships we have with Methodist and with UNMC and with the healthcare and educational systems, it has provided a space for our young people to have people to that are in those professional settings that assist them walking through the mentorship spaces. What does that look like to get enrolled in colleges and things? But also when we're looking like internships for the summer, how do we create spaces? We want our young people and our community members who identify as Native to be in those healthcare systems, but we also want those systems to reflect the needs of those that we're putting into there. So making sure that their policies, looking at policies, looking at the way that they're like not just kind of enter in and then not be able to follow through to get into that ultimate goal of being in those healthcare settings. One of the kind of I have the slide here is says when you are unaware, you are unconcerned. There's a funny story that goes behind this. I'll briefly explain that. I was going to do a presentation at an educational institute in the area, and I ended up rushing out of the house, have a bunch of kids to get to school, got there, was early, and realized that I had two black shoes on that were all black, but they were two different shoes. Not until after I had been running around for a couple of hours to that point did it concern me that I had two different shoes on, but because I wasn't aware of it. But it also comes to the fact is like if we're not aware of the communities that we maybe are not bringing to the table, are not serving in a cultural way, it's not that we don't care, it's just we're not aware of it. Once we can be made aware of how impactful those relationships are, how impactful providing a space that is comfortable for any community member, then you can be more concerned about what does that look like? Are we meeting them where they need to be met? How do we really push them to thrive in education and healthcare settings as far as going into those careers, but also as getting their fullest best health outcomes that we can. If we're not um, if we're not providing those spaces for them, they are not going to walk into them.
I love that, Nicole. It's like we
Anything
can't
else?
advocate for what we don't know about. So
Yeah.
that's all we have. I was going to stop sharing my screen here. I don't know if there's anyone on or if we have any questions.
Yeah, hi. My name is Liz Joseph. I'm one of the co-chairs along with Kylie in the Practice Green Health Practice. I'm sorry, Annie Practice Forum. So my question to you, you mentioned that you work with some hospitals. How strong is your partnership with the population health, as far as community health assessments? And my number two, it's more of a comment than a question. This is a great presentation about community-based initiatives. You should really consider presenting this at the CleanMed conference. I just got back from St. Louis. They have the CleanMed conference every year. So they do have a section just for community programs. I think this is a great initiative, and I think you really should be presenting this at some national forum.
Thank you. So the question was for Nicole, just about like what level of public health, population health, like does their organization do with community health needs assessments and that type of deal?
For us, we do, as an organization, we do our own needs assessments. Everything we do is focused, is very community led, both with youth, outers across the board, to make sure that we're reaching all of the dynamics that we see within our community. We also partner with some of the hospitals and researchers for the universities and stuff around here to get community input, doing like speak freely kind of discussions about public health and education, building that trust, like what has been the barriers, what are the challenges and the experience, but also bringing community into those, and then having them being part of the evaluation process so that they are learning more on what that looks like. There has been a very big disconnect on research and data, especially with the Native community, because of the mistrust of how that data has been used against them historically. And a lot of times people will come in, ask questions, need surveys and things like that, but then it doesn't go anywhere. So where is the follow up, and where is that relationship really building? Like, how do they come back and use that to benefit the community? And so that's a big part of what we do, is providing spaces that are safe for the community members, as well as holding those other institutions, both healthcare and education, to a standard of, yes, we can get the input, but what are you going to do with it? That we have access to all the data and all the information that's collected, that belongs to the community and the organizations, as well as holding them accountable to following up with those needs.
And I'll just add on to that I think that UNMC is one of your guys' partners. Where I'm here with Nebraska Methodist, but there's Nebraska Medicine, which is a huge healthcare institution here, and they're working with you, Nicole, right, on how to collect data about health in a culturally appropriate manner. So there's some research, like I think Dr. Aislinn Rockwood is working on in that realm on that. And I'm very interested in the idea of completing a specific to this population community health needs assessment in order to have data that could then hopefully fuel future funding, because it's hard to get funding without data, as we know. But I do think that we're in that trust building phase of things at this time, and that has to be done in just a really intentional way. So it's something I'd love to explore kind of down the road, with some good mentorship, both from the community itself and through Bluebird and Nicole, and from some folks at my institution and college that have more research experience than I do.
I would say, I think on one of those slides, there was a picture of like the blanket that we had created, and that was actually a memorial blanket that was created with the community through our partnership with University of Nebraska Med, but it was giving us a way to showcase our community members locally that we had lost due to COVID. That is a very culturally significant to have blankets and do memorial things like that. And so being able to merge that, looking at data, sharing those, but even utilizing, like we do a lot with like cancer prevention in the cancer center here at UNMC as well. And so just making sure that we're able to kind of merge both that cultural aspect and the healthcare aspects on them.
Good question. Thank you. What other questions do folks have for us?
Mostly just have a comment to summarize, I guess, and take us on out of this. But I think you both did a really good job of highlighting key strategies that nurses can take away from this, and most importantly, anybody from any practice setting, public health or community, or if you're at the bedside with whatever population you work with, can take away this key message that I heard, which was, if you come with an open heart and an open mind and open ears to listen and center the voice of the community that you're working with, you're going to learn more than you thought you could learn, and identify solutions based on that community voice. So thank you for highlighting that.
Yeah, thank you. Thanks for giving us this opportunity to speak.